have the privilege of introducing our final speaker, notre dernier conférencier, Dr. Gregory Taylor. Dr. Gregory Taylor, who is Canada's Chief Health Officer, and among his many responsibilities is strengthening Canada's response to public health threats. And so I think you'll have a lot of interesting things to share in the context of our conversation today. So please give him a warm welcome.
All right, so good afternoon, and thanks for the opportunity to speak to you. Although I must say I'm doing a few firsts today. I'm pinch hitting for Krista Uthwaite, the president of the agency. She was supposed to talk to you first, but she gives her regards. She's in Washington with the minister. I also, is a first for me because who does a keynote at 4:30 in the afternoon? That's just bizarre. So you've had a full day, and I'm sure you're exhausted and tired, and who wants to listen to some old guy pontificate up here? I've never really spoken ever to a group of lawyers. You're a lot of lawyers, right? Right, it is a law. And so I was trying to think, do I know a good lawyer joke? And the only one I could think about is one that a lawyer told me. So I thought if a lawyer told me that it's okay. And that was when my own personal lawyer, many, many years ago, we were involved in some discussions with another set of lawyers for a whole bunch of reasons. In any case, when he found out the other company that the other lawyer was working for, his comment was, they're so conservative the way they wear their vests in the shower. So you are laughing. So it is a good lawyer joke. So I decided at least I would wear a vest so I would show that. So I also, qu'est-ce que je peux dire à la fin de la journée? After so many accomplished speakers you've had all day, what am I going to say that will be halfway interesting? Because I'm sure you've already heard about the severity, and then we're going back to the pre-antibiotic days, and the global nature of this, and millions of people are going to die, and the sky is falling, and all those numbers and things. So I'm not going to repeat that. I'm going to talk a little bit about what's going on globally. I'm going to talk a little bit about what's happening at Canada at the national levels, and I want to talk a bit about some of the drivers. Clearly, there's no doubt that antimicrobial resistance is a wicked global issue, and I like wicked. Actually, there was a play called Wicked. It was the prequel. You remember that one? That was really good. For a whole bunch of reasons I'll talk a bit about. I think it's worth repeating at the outset, antimicrobial resistance is a natural evolutionary process of survival for bacteria, fungus, and viruses. I think it's worthwhile repeating that. So it's not this new thing. It's been around forever. This was clearly illustrated in 2011 when Canadian researchers were able to analyze DNA from 30,000-year-old frozen soil samples near Dawson City. Maybe you heard about this already today, I don't know. They found fragments of genes that confer resistance against antibiotics such as penicillin, tetracycline, and vancomycin long before we used them. As a result of further work, it was possible to confirm that antimicrobial resistance is ancient. It predates the use of antibiotics since the 40s and part of our natural world. So on the surface, we know that any antimicrobial will have a limited lifespan in treating infections. So as long as we keep inventing new antimicrobials, we could dispense gladly, heartily, lustfully, large amounts of these into the ecosystem without worry. It's kind of like spending money from oil royalties, isn't it? A bit. But the pipeline, pardon the pun, of new antimicrobials dried up while the evolutionary adaptation by microbes seemed to speed up. So the solution seems easy. Discover more antimicrobials and use the ones that are still effective more wisely. Simple, eh? I'm sure you've heard today that it's not so simple. So as human species, we're not very good at solving global issues, be it pollution or global warming, poverty, wars, disease outbreaks, although Ebola wasn't too bad. I don't think we did too bad as a species on that one. So I want to start by giving you a bit of a snapshot of what's going on internationally. Many international organizations have recognized the global threat of AMR and have committed themselves to action. This past May, Canada endorsed the World Health Organization's Global Action Plan on Antimicrobial Resistance, along with the other World Health Assembly member states. There is similar work being done by the World Organization for Animal Health and the Food and Agricultural Organization. The Organization for Animal Health is very active in the development of data standards for the surveillance of antimicrobial use and resistance in animals and establishing a global database. Meanwhile, Canada's endorsement of a national plan paired with global cooperation was reaffirmed at the G7 Health Ministers meeting in Germany last October. The resulting health minister's declaration included a commitment to meet in May 2017 timeline to develop and implement a national AMR plans, or giving the countries time to do that. These international commitments will culminate in a high-level meeting on AMR at the United Nations General Assembly in September of this year. You can clearly see that the very best of international intentions are at work at the international level. However, it's one thing for large international organizations like the WHO to identify AMR as a problem. It's quite another to find a way to take meaningful action when antibiotics are sold over the counter in a number of countries throughout the world. Without a unified response, AMR remains a global threat regardless of good intentions or even the very best policies in place at home in Canada. No matter how seriously we might take AMR in Canada, and no matter what safeguards we put in place, there is always the chance that resistant strains of microbes can simply be flown in. The recent discovery of colistin-resistant bacteria in Canada provides a really good example. Researchers at our lab, and that's the National Microbiology Laboratory in Winnipeg, identified 3 E. coli isolates recovered in Canada containing a new gene that is resistant to colistin. This is quite worrisome because colistin is an antibiotic that is commonly used as a drug of last resort in fighting multi-drug-resistant gram-negative bacteria. La découverte de son résistant au Canada pourrait signifier que la résistance se propage de plus en plus vite chez les agents pathogènes pour l'homme et pour les animaux. This accelerated spread, however, is not a result of overuse of antibiotics or poor stewardship practices here in Canada. This resistant gene was imported from elsewhere in the world and is now poised to present us with problems here. So far, we haven't seen it in clinical cases. I'd like to talk a little bit about antimicrobial drug development. It's really a global issue. The clinical development of a single antibiotic candidate is an expensive endeavor. I don't know if you heard about that earlier in today. That has been estimated to cost approximately $181 million on average for each marketed antibiotic, and that doesn't include the cost for failures. My understanding is that it's much, much higher if you include those drugs that don't make it to market. I understand today that Dr. Uderson already explained, is that true, in some detail the challenges, great, thank you, associated with the entire process, from basic research through to commercialization, so I won't belabor that point. Suffice it to say, and he may have said that as well, the pipeline's broken, and we need to do something about it. Beaucoup de discussions ont lieu à l'échelle internationale pour créer des moyens d'appuyer le processus de recherche et de mise en point des antibiotiques. Along with the models proposed by the Organization for Economic Development in cooperation with the United Kingdom Antimicrobial Review, the United States has instituted the Biomedical Advanced Research and Development Authority, BARDA, which addresses AMR amongst many other health issues. BARDA develops and procures needed medical countermeasures, including vaccines, therapeutics, diagnostics, and non-pharmaceutical countermeasures against a broad array of public health threats, whether natural or intentional in origin. Its focus is on support to the research and development needed to bring about the necessary medical countermeasures to protect public health, including antimicrobials. However, and by the way, as an aside, we don't have a BARDA in Canada, so a lot of us at the agency have kind of dreamed, gee, maybe we should see if we can get a Canadian equivalent of that who can fund those sorts of research. However, the global driver for any development, any drug development, is still profit motivated. And for some reason, antimicrobials aren't profitable. I'd like to use our vaccine as an example of this. As you may or may not be aware, the Public Health Agency developed a vaccine for Ebola that's been in the media. You've seen about Canada's vaccine. It was developed in our lab more than 10 years ago. The development, not that we're in the vaccine business, but we had Ebola in our lab. I don't tell many Canadians that when I talk to the media. There was a lot of worry about the Ebola virus getting into Canada. We've had it for over a decade in our level 4 laboratory. So the development of the vaccine was partially self-interest, protect our staff who are working with that if necessary, and partially motivated by bioterrorism. Ebola has been looked at by the world for quite some time as a potential bioterrorism agent. It was proven in animal models, worked like a hot damn in animals, worked great. So once we had developed this vaccine, again, we're not in the vaccine development business, we looked for companies and advertised the fact who would take it at market. And this was a long time ago. My understanding is you could barely give away the intellectual property. Nobody wanted it. And so you think, well, why wouldn't you want this new development? And it's a new platform. It's actually in the bacteria that's never been used before to create a vaccine like this. It's a genome, partial genome from the Ebola was inserted into the genome of a bacteria. That kind of vaccine hasn't existed. So nobody wanted it. Why? Well, before this outbreak, there had only been 2,500 cases recorded in the globe. So there's no money. That was the truth in the matter. So we did find a company. We did license it to a company who, yeah, they didn't do a whole lot for quite some time. We ordered 1,400 vials of the vaccine. We received those 1,400 vials just at the beginning of the outbreak. So that was in 2014. And the world moved around that. The world moved. And the vaccine now is very, very close to being marketed. It's been highly successful. So the reason I'm mentioning this is an example of a profit-motivated approach to these things. It takes a long, long, long time. Our experience is typical. We talked to vaccine manufacturers, had them across the table with me, and they tell me that it takes typically 10 to 12 years and $1 billion to invent and market a new vaccine. Huge investments. So part of the reason of saying this is what is the balance between profits and the public good? An Ebola vaccine and the creation of that is clearly in the public good, as are new antibiotics and antimicrobials in the public good, but they're not profitable. So how do you get the balance? And what's the role of governments in drug development? Clearly, at the beginning, we kind of do the initial sort of work. We have a regulatory component that does some of the regulatory stuff, which is very important in terms of the clinical trials. And as you heard today, we fund through CIHR and other organizations some of the research, but mostly it's funded by private companies. So are there any processes or statutes of international law that can help us with this? I'm asking that question because you, the guys who should be able to help us with that, I think. So I'll come to Canada. In Canada, we've struggled with the AMR issue just like the rest of the world. Our federated political model has its challenges, for sure, in our 13 different or 14 different jurisdictions. But we don't have a natural national lead for antimicrobial resistance. Quite interesting. So the agency has taken a lead. We're playing the lead role in Canada, but it's kind of on behalf of everybody else because we have none of the levers to actually do anything about it, which is really quite interesting. It's probably part of the reason why it's taken us a while, and the Auditor General very nicely reminded us that we were slow and we better get our act together. So we moved on and tried to convince, believe it was quite difficult to convince other parts of the federal government that this was important because nobody owns this particular problem. We did create a framework on antimicrobial resistance that was released in late 2014, and that was followed closely by an action plan in March of 2015. And the action plan, broadly speaking, is built on 3 interconnected pillars: surveillance, stewardship, and innovation. Surveillance, just an example, a key initiative of the action plan is the launch of the Canadian Antimicrobial Resistance Surveillance System. So for the first time, we have integrated human and animal data from 8 different public health agency surveillance systems into a single annual report. So you'd think that would have been kind of a duh, why didn't we do this in the past? But we've done it now. So for example, using this integrated data, I'm able to tell you that in 2013, approximately 1.4 million kilograms of medically imported antimicrobials were distributed and or sold for use in humans, animals, and crops in Canada. 1.4 million kilograms. I can also tell you that about 78% of those antimicrobials were used in production animals. That's almost 4 times more than the portions sold for human use. Moving on to the second pillar, stewardship. The focus of stewardship is preserving the effectiveness of antibiotics, antimicrobials. In some ways, we've made progress in that antimicrobial use in Canada has remained relatively stable. That's human antimicrobial use in the last 13 years. However, 93% of all antimicrobials used by humans in Canada are dispensed in the community. This accounts for 240,900 kilograms of active ingredients. Our surveillance system so far focused on hospitals, and we're working hard to develop surveillance of community. Is antimicrobial resistance happening in communities? Based on the vast majority of antibiotics, one would think so, but we don't know. Furthermore, these antibiotics that are dispensed to the community translates into big business, very big business. In 2014, for example, $750 million was spent on antimicrobials at the community levels. At the community levels, that's not in hospitals. With that kind of money at stake, business practices and corporate influences clearly have an effect on how we address AMR. So I wanted to tell you just a little story, because oftentimes we point fingers that it's the doctors that are not prescribing, et cetera, et cetera. So I was a family physician a long time ago, and the drug reps, they send reps in. And the drug companies, they know exactly what you're prescribing. I didn't know that until they walked in. It's because they have this system at the pharmacy, and they know which doctor and exactly what they're prescribing. All pharmacies in your area. So the drug rep came in to see me. And, of course, the drug reps seeing the doctors are usually young women, well-dressed, very attractive. And so this woman came to talk to me about a particular drug that I was not prescribing. And she had come back a couple of times, and I still wasn't prescribing it. So she came to my office, stared me straight in the eye, and said, "Dr. Taylor, is there anything I can do to get you to prescribe this drug?" So needless to say, I kind of took a couple of blinks and said, "No." That's just a small example. You probably saw the media recently in Ontario where the majority of CMA provided comes from drug companies for physicians, education. And that kind of influence is alive and well and has been alive and well. And what drug companies do is they try to make you believe, and I was a family doc working in a small town, that if you're not prescribing the various latest antibiotics, somehow you're inferior and you're really not up to speed and you're not up to date. And as much as you can do your reading, it's hard to resist that sort of influence, I think. So that's only part of the story. Educating prescribers, and both MDs and other people who prescribe, is key. And we do have some evidence. The agency has done some studies that say that it seems to be working, and prescribing practices are improving. But beyond just the prudent use of antimicrobials, there's infection prevention and control. If we reduce infections through prevention, we can reduce the use of antimicrobials. On the animal side, while distribution and use rates have remained stable, the main challenge is that 73% of antimicrobials distributed in animals were in the same classes of those used in human medicine. Government of Canada and my colleagues in Health Canada have made significant progress in strengthening regulations on the use of antibiotics in the agri-food industry. Antibiotic use in animals for the purpose of growth promotion has been targeted as an area for action. By December 2016, growth promotion claims will be removed from all medically important antibiotics for animal use. Further regulatory changes will be made on veterinary oversight of the use of antibiotics and on the importation of antibiotics by farmers. Innovation, that's the third pillar. That's where all the cool stuff kind of happens. It's more than just the cool stuff. It's also things like role of government and funding of new drugs. But there's a whole bunch of things that are coming down. I just want to mention a few. Designer vaccines. We have a company that's set up in Canada which makes vaccines from tobacco plants, believe it or not. And they can make it very, very quickly, and they tell me at a fraction of the price. What that opens the door is this designer vaccine. So that Ebola story I told you about, where it wouldn't make sense economically, that's changed. And they're telling me, and as they develop this, they're opening a big plant in Quebec City. We may look at that as part of the solution. You don't need an antibiotic if you've got adequate vaccines. The hospital folks tell me they've got different sorts of technology. They irradiate an entire room in cleansing instead of using antibiotics. That's interesting. Antibiotic adjuvants, these are things that help existing antibiotics work better. You give them an adjacent with them. Monoclonal antibodies, that's another thing our laboratory does. And those are taking and creating synthetically the antibodies that your body would create to fight off an infection and giving them. So did you see the media around Ebola, the ZMapp? Anybody see that, that treatment? No. Okay, ZMapp was something that we co-created with the U.S. That's monoclonal antibodies. Very, very promising again, and you shouldn't be able to get resistance to that. And rapid on-the-spot bedside diagnostics. So if you're a physician seeing somebody and you can tell immediately whether it's a viral or not, you stop using the antibiotics. I think one of the most interesting emerging technologies is the application of genome sequencing. So the colistin thing I told you about, it was genetic sequencing we looked at. We didn't actually do a typical test on bacteria. We looked at the sequencing of that. We used to do in Canada partial genomic sequencing. We're now moving to full genomic sequencing. It's actually quite easy to do. We're using them for foodborne outbreaks, and that gets you into an era, big data, huge amounts of data, but you can map out the genes and map out how they're going and actually watch the evolution of some of these organisms. I think it's important to understand that innovative solutions and new ways to approach the challenges we face are out there, as I mentioned. So back to the federated political model of Canada just for a minute and closing. Under Canada's federated system of government, responding to the threat of antimicrobial resistance is challenging, as it requires a cooperation of multiple government jurisdictions and authoritative bodies, each acting with their own specific mandates and areas of responsibilities. So in some ways, Canada's kind of like 13 different countries. I just had a meeting with the Minister of Health from Aruba, and I learned, I didn't know this before, there's 3 Caribbean countries, I forget the other 2, which belong to the Netherlands. And so, but they're autonomous. So it's very interesting. They have the same passport, same money, but they're autonomous within, which is quite interesting. I kind of thought, dude, that sounds like Canada. They do their own thing, and Quebec would probably say that they're autonomous, but they still are under the Canadian flag and the same sort of passport. But they function independently and they make their own decisions. That's part of Canada's, I see it as greatest strength and greatest weakness, keeps us strong because we naturally collaborate. But when you try and do things together, it can sometimes get cumbersome at best. So the good news with this is we have managed to get all of the provinces and territories on side. They all believe this is an important priority. Within the Public Health Network, that's a network that I co-chair, we've managed to convince all the deputy ministers that this is a priority, and they've tasked us to create a new governance model. So what we're building in this governance model is a structure we've never done before in Canada. So the Public Health Network structure that was created, a formalized federal, provincial, territorial, was created post-SARS, never happened before. Now we're creating one that involves public health, healthcare, and the animal sector. So we're putting this thing together and we're trying, which on the surface of it sounds great, although it's a little cumbersome. And we can't wait for that to get into place for all the actions and things that need to happen and need to move on. So it's kind of that tension between getting the governance and working collaboratively in the meantime, helping things move that have to move to the local level. So where does that leave us? I'm actually optimistic. We have some time. It's not as if the doom and gloom is going to happen next year. And there is change happening. We're creating new structures like never before. There's technologies we've never had before. There's an awareness like we've never had before. And there's a global cooperation around that's never happened before. And I think Ebola has helped this. But you can't let up. We have to keep our focus. We have to keep our eye on the ball. Otherwise, we'll lose the focus. And there's still a lot to be done. So thanks for the opportunity, and I'll get out of your way.
We'd like to thank Dr. Taylor again for that great presentation. And just in closing, a couple words from myself and from Matt, co-editors-in-chief of the Law Review. So I don't know if, Matt, you want to take it away.
Yep. Sure. So first of all, we wanted to thank our speakers, our moderators, and our guests for contributing to today's event and to the tremendous success and the great exchanges and dialogue that we've had. So thank you very much to everyone. Secondly, we wanted to thank our partners, the University of Ottawa's Global Strategy Lab and the University of Ottawa's Centre for Health Law, Policy and Ethics. And to our sponsors, the Canadian Institute of Health Research and the University of Ottawa, for which this event could not have been put on today. So thank you very much to them. And last but certainly not least, to our organizers, we have Layla Ashurov, Catherine Gauthier, and Daria Vodova. Your work in putting this together started last summer. It's been a long road, grant applications, and everything else that went into it. So thank you very much for your leadership and your hard work. And we also have our associate editors, Natasha Milne, Kimberly Pollard, Katie Dergendorfer, Heather Mason, Catherine Dion-Gagnon, Alexandra Bayek, and then a long list of other Ottawa Law Review editors who are involved. So thank you very much for your hard work. So, and at 5:30, from 5:30 to 7:30, we'll be having a reception at the atrium in Fauteuil Hall, which is the law school. So you're all welcome to attend. There will be food, which is great, and a cash bar as well. So we'll hope to see you there. You can just follow us. It's going to be a big group heading there. And just so you know, today was live streamed. We've had some really great feedback online, and then later on it will be made available on YouTube, and hopefully we'll get some traction as well. So thank you very much, and we'll see you later on.